Okay, good afternoon, everyone. My name is Mike Udell, and I am a professor in the Department of Community Health and Prevention here at the Dornsife School of Public Health. And it is my pleasure to welcome you all here this afternoon to join us for what is our final in a year-long virtual population health spotlight series. And we are so pleased today to have Dr. Chandra Ford, who is joining us and from UCLA, and I'll give a brief bio on Dr. Ford in a moment. This has been quite a year, and it is a year that ends on some both hopeful notes and on some continuing challenging notes as well, with all that is going on around us in the world. And I can't think of anyone better in the public health world to bring some of those issues to the fore today in Dr. Ford. So welcome to the Population Health Spotlight, and let me introduce Dr. Ford. Dr. Chandra Ford is Professor of Community Health Sciences and Founding Director of the Center for the Study of Racism, Social Justice, and Health in the Fielding School of Public Health at the University of California at Los Angeles. In 2019, she served as the lead editor of Racism, Science and Tools for the Public Health Professional. She earned a doctorate in health behavior from the Gillings School of Global Public Health at UNC Chapel Hill and completed a postdoc in social medicine at the University of North Carolina School of Medicine and in epidemiology at Columbia's Mailman School of Public Health, the latter as a Kellogg Foundation health scholar. Dr. Ford's work offers conceptual and methodological tools for studying racism as a public health problem. She originated with Collins, Airhead, and Bua, the public health critical race praxis, which is a framework for applying critical race theory empirically. Much of her empirical work examines inequities in HIV testing, care and prognoses, or documents barriers to services among LGBTQ survivors of intimate partner violence. Her work has been published in the American Journal of Public Health, the Boston University Law Review, Ethnicity and Disease, Health Promotion Practice, the Journal of Acquired Immune Deficiency Syndromes, Social Science and Medicine, and other distinguished peer-reviewed journals. Dr. Ford has received many teaching awards and several notable honors, including the 2020 Wade Hampton Frost Award from the EPI section of the American Public Health Association, a Lifetime Achievement Award from the Association of Black Women Physicians, a True Hero Award from True Evolution, and the 2019 Paul Cornely Award from the Health Activist Dinner Group. Dr. Ford serves as the profession extensively. In 2016, she served on the National Academy of Medicine's Committee on Community-Based Solutions to promote health equity in the United States, and was named co-chair of the Committee on Science and the American Public Health Association's new formed Anti-Racism Collaborative. She's a longstanding member of the American College of Epidemiology's Minority Affairs Committee and a former president of the Society for the Analysis of African American Public Health Issues. In addition, she has been involved with the Black Radical Congress and partnered with the Black Coalition Fighting Back Serial Murders. I also want to add, on a personal note, Dr. Ford's work has been an inspiration to my own work, and I am so delighted to have the opportunity to introduce her today. Dr. Ford.
Thank you. Thank you for such a warm reception. I want to thank Dean Diaz-Rue and also Dr. Barber, as well as Diana for Diana Marshall for all of the assistance getting us to this point. I'm going to go ahead and share my slides. So I have to admit that being a Pennsylvanian, it's a delight to be here at Drexel and in Philadelphia, if only virtually, because I'm from an area not that far from here. I was asked to speak for about 45 minutes on some pressing topic of the day in public health. And I have decided to focus on an issue raised by a statement that happened last week, as you all know, and that is the declaration by CDC Director Walensky that racism is a threat to the health of the public. What I'd like to do today is talk about ways that critical race theory, in particular public health critical race praxis, the health equity offshoot of it that Collins, Ari, and Bua and I have worked on might help us to think through potential solutions. I'll start by defining racism, characterizing the current social climate, which is an important thing to think about as we think about how to address racism as it is in the current moment. Introduce critical race theory and public health critical race praxis, highlight several cautions that might arise as we think about racism in more sophisticated ways, and offer recommendations and potential resources that we can all draw on. I conduct my work in Southern California on lands originally inhabited by the Gabrielina Tongva peoples. And it's important for me to acknowledge this as one who directs a Center for the Study of Racism, Social Justice, and Health, and as a person who identifies as African American, because just because we're working for good does not mean that we are not also benefiting from the injustices visited upon the original inhabitants of this land. Last Thursday marked a real pivotal moment in the history of our nation and of our field when Dr. Rochelle Walensky declared that racism is a serious threat to the health of the public. Racism can be defined as a system of structuring opportunity and assigning value based on the social interpretation of how one looks. That social interpretation unfairly disadvantages some, it unfairly advantages others, and as a consequence, it saps the strength of the whole society. That definition, of course, being offered by former president of the American Public Health Association, Kamara Phyllis Jones. To this definition, I would add the following one, offered by the critical social geographer, Ruth Wilson Gilmore. She defines racism as, quote, the state-sanctioned and/or extra-legal production and exploitation of group-differentiated vulnerability to premature death. And though it may not be apparent initially, this definition is actually quite relevant for public health and in particular for epidemiology. It focuses on populations, the ways in which racialization creates and structures them and orders them. And it insists that racism can only be understood through a consideration of its link to the physical body and ultimately to mortality, which implies it is concerned with risk and morbidity. The nature of racism changes over time and context. In the early 21st century, there are complex symbiotic relationships between structural forms of racism, laissez-faire racism, and overt forms of racism. So the structural and laissez-faire being more difficult to perceive, and the overt forms obviously being those such as avowed neo-Nazis marching in the streets. There are marked global and domestic shifts, global and domestic demographic shifts. And these shifts are tied to histories of domination and contemporary globalization, both of which reflect racialization. The meaning, content, and structure of US racial and ethnic categories are changing. So who fits in which categories? And the long-term implications of this shift, of this sort of change in the demographic categories can't be known right now. We're right in the middle of it. Nevertheless, there are a number of theories about what kinds of changes we might see over the long term. And for us in public health, we are charged with making decisions and taking actions, estimating effects nevertheless, regardless of whether these changes are going on. Drawing on the work of folks like Edward Bonilla Silva suggests that we might be seeing something, for instance, like the Latin Americanization of race in the US. And if so, this would be marked by several things, among them a greater sense among individuals that race is not salient, doesn't affect how they see life and how they think. a sort of color blindness, while at the same time a persistence of anti-Blackness. According to Bonilla Silva and others in different approaches, this transition would include three major categories: a white category to include European descendant persons and pale-skinned non-Europeans who share an American sociopolitical orientation; an honorary white category, which includes most non-Black people of color; and a collective Black category, which would include all persons already from the African diaspora and normally, quote unquote, categorized as Black, as well as dark-skinned Latinos, Asians, and Pacific Islanders. And if this hypothesis is true, basically, so what? It matters because if this hypothesis is true and levels of racism in society do not diminish, we would expect to see disparities due to racism begin to affect those in the collective Black category who are not already categorized as Black. And so we would expect to see folks in the Pacific Islander and dark-skinned Asian and Latino categories begin to have the health profiles that we now associate with African Americans. In the early 21st century, there are also robust bodies of knowledge about racialization, its intersection with other social injustices, the effects on health. And so that's an important resource that we have in the early 21st century. And finally, there are many anti-racism social justice movements with whom we in public health can partner to guide the work of health equity. There are a number of reasons why it's important to talk about racism right now in the middle of a pandemic. One, it persists. Two, during pandemics, certain kinds of racism intensify. And three, we cannot achieve equity without addressing racism. So racism persists both in our society, it adapts and it evolves over time, so it does not always look the same, but it does persist. And it's relatively easy to point to its most overt forms, the hate crimes and the hate incidents. That stigmatization and hate crimes have targeted Asians since the very beginning of this epidemic underscore how inextricably linked racism and the COVID-19 pandemic are. And I would say racism and health outcomes more broadly. The more fundamental way racism affects health, though, are these less conspicuous mechanisms, the structural forms of racism, environmental racism, and so on. As with any, the study of any particular topic, it's important to have appropriate tools to look at it. And for me, critical race theory, which emerged as a way to understand the contemporary ways that racism operates, is critical to being able to identify these less conspicuous forms of racism. As many of you know, a substantial body of evidence exists that shows that racism is not only a social problem, but a public health problem. It's important to think about the implications that it has not only for health directly, physiologically, but also through its impact on access to and quality of healthcare. As these books indicate, and my former peer as a Kellogg Health Scholar, Dr. Shalon Irving, the stories of African-American women that have been coming forward in the media, experiences of maternal mortality or near maternal mortality, as well as preterm birth and other birth-related outcomes, really underscore that simply improving access to care is not sufficient to address the ways that racism influences the kinds of treatment that people receive within the healthcare system. And it's important to think about these intersectionally because these effects are not categorical. In qualitative research I conducted among lesbian and bisexual survivors of intimate partner violence, we learned that racism affects both access to and quality of care in this intersectional way. And the aims of this work were really to document the experiences of lesbian and bisexual women survivors. This is earlier work that I've conducted. It's just that during this pandemic, these concerns and the need to link to an intersectional understanding of racism are very salient right now for me. To identify subpopulation-specific barriers was a second aim, for instance, among particular racial or ethnic minority populations, among masculine women, for instance, bisexual women, and to obtain recommendations from these women about how to facilitate access to care among them. And I do just want to give you a heads up that I will have a few slides here that have triggering content due to violence. Bisexual men and women have higher prevalences, lifetime prevalences of rape, physical violence, or stalking, and also of other forms of intimate partner violence. Among women, lesbian and bisexual women have higher prevalences than do heterosexual women. These data are from CDC's National Intimate Partner and Sexual Violence Survey. Just to characterize what intimate partner violence looks like among lesbian and bisexual women, and this is important because one of the recurring themes, in fact, actually one of the strongest recurring themes that came out of this work was that survivors had their concerns about intimate partner violence diminished by the very professionals from whom they were supposed to be getting help. And so allow me just a few moments here to characterize what intimate partner violence looks like among these women, even though the women themselves did not use the term intimate partner violence. Many of them did not even recognize that what they were experiencing was intimate partner violence. Shira was describing a situation by saying, quote, she wanted to have sex, but I resisted. She got on top of my chest and was strangling me. I just blacked out, and I don't know how, but I came back. And what's not apparent from this statement is that her partner is actually is licensed as a her hands have to be registered because they're considered deadly weapons due to her excellence as a martial arts expert. And this was a very diverse sample. Anna said, and she just, without thinking, clenched her fist and punched me twice in the nose. And I went down really fast. It immediately swelled up really fast. I ended up getting a concussion and going to the hospital. Another woman, Aretha, was describing an experience she had. She said, I was at the club and I saw her go up and shoot her ex-girlfriend in the head and kill her. I witnessed this. So as you can see, first of all, these assumptions, these statements challenge any assumptions folks might have about violence among women being just catfights or, kind of nice, not really that bad or that serious. But this also gives you a sense of the focus of the project, which was squarely on violence and not explicitly focused on racism. However, as a central part of every focus group, we had an exercise that opened up each focus group, through which it became clear to us how important it was to think about racism, even in the context of something like intimate partner violence. So mistrust and fear of law enforcement emerged continuously out of this exercise, where participants were focusing on what are the resources that are available to people who are experiencing intimate partner violence? And shockingly, one resource that was never mentioned was the police. And so it really was through exploration of why are you not talking about the police as a resource that people rely on as a result of intimate partner violence, that we learned that the reason for many of them, certainly all of the Black and Latina participants, and many of those who are not Black or Latina, was because of the way they had their personal experiences with non-intimate partner violence interactions with police. Prior experiences tied to intimate partner violence with the police, or totally no experience whatsoever personally with the police, but their stories that they had heard from people in their small networks, in their family, etc., and what they had witnessed, but not personally experienced themselves with police brutality or violence against Black and Latino people in particular. And so, regardless of the race of the participants, the concern with police acting in forms of racist policing was a concern about could that kind of racialized policing transfer into homophobic or transphobic policing with respect to intimate partner violence. It's important to talk about racism right now today, in part because racism intensifies during epidemics. And scholars have documented this with respect to cholera in Venezuela in the early 1990s and in Haiti in 2010. Often a response, the scientific and the public health community's response to pandemics is to focus very narrowly on the, in this case, the virus with COVID and the immediate solutions tied to that. But what we know, if we think about racism, is that the ways in which transmission occurs, the risk of the pandemic persisting in pockets of vulnerable populations, vulnerable communities, those things are shaped by racism. Strong parallels exist between racism and stigma in the HIV epidemic and racialized stigma in the COVID-19 pandemic. In both cases, the stigmatization reflects the specific ways that a particular group has already been racialized. So what I would say is that whereas some describe the stigmatization of Asians today tied to COVID-19 as somehow or another just specific to COVID-19, in fact, the ways that Asian populations are being stigmatized and targeted in the COVID-19 pandemic merely reinforces ways in which Asians were already being stigmatized and subjected to racialization over the course of our country, over the history of our country. And similarly with HIV, stereotyping of Black people as disease-ridden, prone to engage in illegal and sexual behavior, reflected existing stereotypes about Black people that predated the HIV pandemic. And there's much that we can learn from this. And I realize this print is rather small. I tried not to have many slides like this, but findings from some of my work on racism-related conspiracy beliefs and HIV testing suggests that the relationships are more complex than what some suggest. And I think this is important to think about in part because those who are affected by racism also exercise agency in responding to it. And in this small study, which was conducted among older adults in high prevalence and high risk contexts, such as needle exchange sites and STD and HIV clinics, we observed differences in HIV testing by the type of conspiracy belief that individuals do or do not endorse. So right now, we're concerned very much about how conspiracy beliefs and mistrust might affect vaccine uptake in terms of COVID-19. With respect to the HIV epidemic, there has been a fair amount of work to understand how conspiracy beliefs affect care seeking, testing, etc. First of all, we observed that conspiracy beliefs were prevalent across racial and ethnic groups at about 30%, and not just African Americans, as has often been suggested. But with respect to testing, only mistrust of the government was associated with lower odds of getting an HIV test in this population. endorsing conspiracy beliefs. And by conspiracy beliefs, I mean believing that the government or pharmaceutical companies created AIDS as a way to commit genocide on Black populations. I mean that explicitly. That folks who endorse those kinds of beliefs actually were more likely to test. And there is research elsewhere to confirm and corroborate those kinds of patterns. And it suggests that for some, knowledge or concerns or worries about conspiracy beliefs actually might lead them to be more proactive in terms of protecting their own health. What can we do to address racism? So much is focused on documenting racism, naming racism, because for so long we literally have not been able to do that in the field. But now what do we do to address it? And I want to suggest that we center equity, embrace anti-racism, and take evidence-based action. Equity, again defined by former APHA President Kamara Jones, can be defined as assurance of the conditions for optimal health for all people. I like to put it in the active to say, to assure the conditions for optimal health for all people, because it reminds us that it's not a state, but that it's something we should be doing. To achieve health equity requires valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. A second solution is to undertake anti-racism research and work. And this requires going beyond documenting the disparities to taking a stance against them within the field. And let me explain what I mean. Stephen Thomas and his colleagues, some 10 years ago, generated a model of what they consider the 4 generations of disparities work. The first was merely to document the existence of disparities. And to us now, that might not sound like a big deal, but prior to then, there was not a commitment to acknowledge that disparities exist. The second generation was focused on explaining factors contributing to those disparities. The third generation focused on developing solutions. And according to Thomas and colleagues, we are now in the 4th generation. And they recommend we apply public health critical race praxis and perhaps other critical approaches to use to guide us in doing anti-racism research. And anti-racism is a commitment to dismantle racism across all socioecological levels. It involves acknowledging the destructive power of racism in society, attempting to ameliorate it, and maintaining a critical stance toward racism and racial exclusion within our field, so in society as well as in our field. Anti-racism research challenges racial research directly. It studies what marginalized communities identify as priorities, and it generates the theory and methods needed to take on this anti-racism orientation. And we can conduct anti-racism research. A central concern of mine has been research by challenging racist research directly, raising these overlooked questions, and again, developing new approaches and tools. Now, critical race theory originated in law in the late 1980s among legal scholars of color who were really looking for ways to understand exactly why is it that in the post-civil rights era, racial and ethnic disparities persist, even though ostensibly our nation has embraced a, 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 an equitable orientation. It has been defined as a collection of activists and scholars interested in studying and transforming the relationship among race, racism, and power. And so here, what I would say to draw a distinction between, for instance, critical race theory and multiculturalism is that whereas multiculturalism aims to integrate us all into an existing system, critical race theory is concerned with understanding and illuminating the flaws with the existing system, taking down that existing system, and creating something that has the infrastructure needed for us all to be able to exist and work and thrive in it equitably. This reflects its critical orientation. This critical paradigm is one that holds that there are multiple realities, socially constructed, and that power imbalances embed these realities. And it is the obligation of the researcher to identify and illuminate these power imbalances. For critical race theorists, these power imbalances are inherently racialized because racism remains a dominant axis of every dimension of our society. And we do this illumination by, first of all, knowing and understanding and articulating our own values and positionality, especially relative to a particular project. The public health critical race praxis is a racism-based, primarily research approach that Colin, Thari, and Bua and I organized some 10 years ago. And our goals were to bolster the capacity of public health and health equity researchers to conduct what might be recognized as rigorous research that explicitly targets racism while at the same time advancing anti-racism movement in the field of public health. So this approach has an explicitly racism conscious orientation. Many people use the term racially conscious or race conscious. I'm using the term racism conscious in order to draw attention to the fact that it's not that we're focused on identifying phenotypic differences between people or populations, but that we're focused on developing an understanding of the ways that racism is acting on those phenotypic differences. A second key component is the lexicon that we borrow largely from critical race theory and use as building blocks for the final component, which is a semi-structured, self-reflective research approach. For us, every single project is guided by two questions. First, how is racism relevant to this problem? And then secondly, how does racism influence the production of knowledge about this problem? Together, these two questions help us to first of all, understand what's going in terms of the health inequities out in society. And then secondly, to think about at the same time, how our field is complicit with this and how we as individuals or as institutions may also be complicit with it. This is the process, and I'll just mention it briefly here. It's an iterative process that starts with assuming a racially conscious orientation, and you see that here with this racism conscious lens, and then proceed through these four focuses. And a focus is where we literally sit in concentration and work and discussion to iron out an understanding of these explicit concerns, using the principles and the terms of the lexicon that I just mentioned a moment ago. So the first step is really to characterize current contemporary racial dynamics. And by contemporary, I mean those of the time period of interest for the study. So if we are talking about what's happening with COVID today, the racial dynamics of interest might be those happening on the streets today. But if we're talking about the experiences of older adults, we might need to think about about the racial dynamics that they were experiencing at different decades over the life course and characterize it appropriately. In focus 2, the researcher clarifies biases in the field that might inform the current project. And this is important because empirical research is an incremental process, and each study can only contribute some small portion to an existing body of knowledge. Critical race theorists reject out of hand the idea that knowledge, even scientific knowledge, is inherently bias-free. And so the goal here is to understand what are ways in which racialization may have already informed that knowledge on which our current study is supposed to be based and is supposed to build. So we want to make those clear. In focus 3, the goal is to draw on the prior focuses to operationalize the measures. And the process comes full circle with focus 4, where the researcher takes some kind of action. Now, again, empirical research is incremental. In most cases, it would be inappropriate to take the findings from one small study or one study and launch into community and make some major intervention just based on that one study. However, there is much that can be learned either from the research findings or from the research process. In particular, if that process is, as we recommend, community engaged, iterative, and so forth. So what can we learn from the research process as well as the research findings to make some impact on those inequities? These are the building blocks for the process and for the work. I want to just highlight 3. Race is a social construct, the social construction of knowledge, and critical approaches. Now, the statement race is a social construct is now widely asserted within public health. I think it's important to draw attention to the fact that this statement has 2 connotations. One is a statement about what race is not. That statement is contesting what race historically has been treated as within our field. So that statement, when we hear race as a social construct, is really saying, no, race is not fundamentally biological. And that's true. But there is another connotation, and that connotation tells us what race is. Race is meaningful. Race does exist. Race does impact our lives. That means that that's the affirmative connotation of race as a social construct. And Ian Haney Lopez defines this social construct as a vast group of people loosely bound together by historically contingent, socially significant elements of their morphology and or ancestry. And just by contrast, as an exercise, think about how one would make that into epidemiologic categories. Heyman and Levitt go on to say, race becomes in social fact what it's supposed to be in naturalist theory, a differentiating trait that orders us in hierarchical terms as members of inferior or superior races. Now, these days, we would rarely use the language of inferior or superior races. Nevertheless, our approaches can reinforce this understanding that there are certain groups that fall in higher locations socially and others that don't. And this is important to stay attentive to this possibility of normalizing inequities. So much of our focus in terms of challenging the biological determinism of race has overlooked the ways that ethnicity is also a social construct. And Naina Harawa and I propose that we think about ethnicity as having 2 dimensions. One is the attributional dimension that we so often think of when we think of ethnicity. This is where we think about culture, language, etc. And these are shared dimensions of social life that are not, at least in the same ways, imposed upon members of a group. The relational dimension is the one that is particularly useful for us, for those of us who are concerned with health inequities, because it helps, it says that ethnicity, like race, reflects relationships between ethnically defined populations. It reflects the hierarchies and the social ordering of populations. And ethnically defined populations can experience racism. Their experiences of racism may occur along axes that we're not thinking about because we haven't managed to tease out what are the many different hierarchies along which ethnically defined populations might be categorized. And so what we propose is that in doing social epidemiology research, in doing health equity work, and in doing public health practice, that we think about ethnicity, that we think about how we might highlight the axes along which particular ethnically defined populations are most likely to be subjugated or to experience harm socially. If we think about the different social hierarchies that exist in our society, whether they are along the axes of skin color, if they are along the axes of hair texture, religion, where do these ethnically defined populations fall along these particular hierarchies? So by using one or another ethnic category term, we may miss specific ways that different ethnically defined populations within that ethnically defined term or across it are actually likely to experience inequities.
Dr. Ford, 5 minutes.
Thank you. So I think it's important, just as with thinking about race and ethnicity, and clearly this stands out for us, given what I've just shared, that as the epidemiologist Steve Wing once said, data never, excuse me, this is Larry Bobo said, data never speak for themselves. It's the questions we pose and those we fail to ask, as well as our theories, concepts, and ideas that bring a narrative and meaning to marginal distributions, correlations, regression coefficients, and statistics of all kinds. And we argue, Collins, Ari, and Bua and I, that the systematic nature of the scientific method enhances its reliability, the reliability of the findings, but that does not necessarily eliminate the influence of racial bias. And the social construction of race and ethnicity, as well as the social construction of knowledge, are not just esoteric ideas. They suggest, for instance, that these data reflect social exposures, not group characteristics. They also force us to consider new questions when viewing data like this, such as, how is racism operating here? Who counts as American Indian or Alaska Native, Black or African American, Hispanic or Latino? We cannot address a problem if our data do not allow us to see it. Data issues have existed since the beginning of this epidemic. They include the failure to collect or report race and ethnicity data, reporting the data for death and diagnoses, but not for other outcomes, which would have given us more lead time to be able to reach particularly vulnerable communities, missing data, as well as a large group of other race and ethnicity category data, which remains extremely heterogeneous and therefore, in many cases, unactionable. There are a number of approaches that I think can be useful from a critical race theory perspective: centering the margins, assessing our a priori assumptions, taking direct action, engaging in counter storytelling, that is, valuing the narrative experience of those from the margins and allowing those stories to drive where it is that we take our work, using first-person voice in our empirical work to draw attention to the ways that it is not entirely objective, and then critiquing the canon, that is, to approach our field and to do the work ourselves that is required to understand and illuminate how racism is operating within the field. We have tried to assess our own a priori assumptions in my work. Thus far, we're still doing it qualitatively. What it has entailed is literally surveying each member of our team during the course of a project and throughout the project, generally before each new aim is undertaken, asking questions like, and we do this, a non-research staff member carries out each questionnaire through, for instance, SurveyMonkey, and we don't always share the results. These are open-ended questions that ask each of us to talk about what we expect to see in the results, how certain we are that we'll see them, what kinds of disparities and why we expect to see them. And yes, people do say things like, I guess, I suspect it, I just have a feeling. Simply asking these questions is itself an intervention, is what our team members have suggested, because it forces us to think about how we're going into the work and what kinds of conclusions we are likely to embrace. When we're looking at the findings, which kinds of assumptions, which kinds of conclusions we're more likely to carry forward. I want to emphasize that in the COVID-19 pandemic, I think it's particularly important to be attentive to the ways that data, big data, are increasingly used in ways that exacerbate power imbalances. And much has been written about this outside of public health. So addressing racialized power imbalances during the COVID-19 pandemic, the first pandemic in which system science and big data have been used so reliably and helpfully. Addressing racialized power imbalances will be critical to achieving health equity. I also want to just conclude by offering two more things, and that is, first, we can play a role in addressing structural racism. And for those of us who use social ecologic frameworks, thinking about macro level influences automatically gets us to focus on policy. And we have done it, literally bringing critical race theory explicitly to the work that we did with Congresswoman Ayanna Pressley to help inform HR 8178 and other work to address racism as a public health issue. And this was actually during the Trump era. So I say that to say we can be bolder sometimes than we think we can be. There are also a number of tools available to us today. And so I offer at the start these three books because first of all, there was so much work that went into them. And they're intended to be resource tools that public health practitioners and researchers can draw on in very concrete ways to carry forward health equity work that is explicit in addressing racism. And with that, I am going to say thank you.
Thank you so much, Dr. Ford. That was just an incredible talk, and it provides, so much context for all of the important work that not only you're doing in terms of thinking about racism as a public health issue, but it really informs, the broader questions that so many of us in public health are asking about the relationship between different social determinants of health and how public health can distinguish itself during this really difficult time, both in terms of the pandemic of COVID and also the pandemic of police violence and racism that we are all facing right now. I'm going to ask the many attendees out there to please share questions in the Q&A box, and also to make a request to our students who are listening that if you'd like to have some one-on-one, some small group time with Dr. Ford this afternoon, that'll be held at 4 o'clock, and you can email Diana at dlm386@drexel.edu to request to be a part of that. So while we wait for some more questions to pop up in the chat box, I want to ask you a question. So you spoke a little bit about, race being a social construct and not being biological. And I'm wondering if you could take a minute just to dive a little deeper into the challenge of studying racism versus sort of the contrast of race and the way it's used ubiquitously in society, where it has these biological connotations. Obviously, that's not how we generally use it in public health, although sometimes it is used that way. How do you thread that needle by using a variable that is so fraught with needing to understand the way in which racism has such a terrible impact on individuals and populations?
That's such an important question, and it's a very difficult question to resolve. The problem is, when we see race, what do we see? And when we say that it's a biological construct, or if we don't say that, the default is we see something about an individual or a population, a characteristic of them, an attribute. What we really should be looking at is when we see race, and I'm talking about shifting the focus, that what we see is a signal, is an index that here is a population that is likely to experience some exposure. So race as a social construct is really an index, a flag, a sign of a population that's at risk, greater risk for particular kinds of treatment in our society. And so when we see race, we really should be looking at what kinds of treatment occur as a consequence of this characteristic.
Mm.
That's a real oversimplification of it, in particular because I tend to think in terms of racialization rather than racism, in order to draw attention to the relational dimension of it, the fact that we're talking about different groups rather than even the racism literature sometimes can treat racism almost as an attribute of an individual or a group rather than an experience or, so that's an experience or a social force to which groups are subjected.
Yeah, I appreciate your answer, and I think you're right on everything. But the challenge, and it's a challenge that you've been thinking through in a methodological way and in a leading way, which I'm grateful for, is that tension that you describe. I want to jump to a question from.
Can I just add one thing?
Oh, yeah, go.
Okay. So I think it's also important. There are two what I consider to be major challenges to advancing that shift. One is that the terms race and ethnicity and the different categories that are used are ubiquitous in our society. And so everyone has a sense of what race and ethnicity are, what they mean, how serious racism is, those kinds of things. So that makes it really difficult to then see there is actually a body of work someplace that illuminates how it really operates more meaningfully. And the other is if we think about the ways that knowledge um, is valued or not. We still in public health tend to value biomedical forms of knowledge, very quantitative forms of knowledge, quote unquote, more harder science. And those forms of knowledge production rely heavily upon the, the, the categories of race and the ways of understanding race that fit that. And so I believe that part of what would help us to move in a different direction is actually addressing the hierarchies within our field, because the different kinds of knowledge production requires different kinds of knowledge require different kinds of elements to produce them. And so I would say that part of the challenge is that some of the dominant forces driving our understandings about disease and so forth rely on those flawed understandings of race and ethnicity.
I'm grateful that you pointed that out, and I'll just add, last month the NIH issued a new set of policies and approaches to look at structural racism internal to NIH and how it impacts intramural and extramural scientists and funding. The one thing that it left out was, questions about, this, which is obviously you and I have spoken about before, which is sort of how to study populations. And the other piece, of course, is we know that, the federal funding system favors certain types, funding certain types of research over others, which puts certain types of research at a disadvantage.
It does.
But we'll continue to have those discussions. So I want to get to this question from a member of the audience who asks if you could speak to strategies to push back on the narrative that structural racism doesn't exist, particularly when these narratives are supported and perpetuated by very powerful voices. For example, they point out the recent JAMA editorial and podcast, which, two physicians denied that racism existed within medicine. It's been taken down. There were some issues with how it's, tried to be brushed under the rug by JAMA. But wondering if you have any thoughts on the larger question about this counter narrative that structural racism doesn't exist.
I think that here, in particular, in speaking to those audiences, meaning the JAMA audiences, for instance, that it's important to use the rules that those fields and disciplines and institutions and structures themselves establish. And those rules include that you're supposed to base what you say on the evidence. And so I believe we have a responsibility to hold people, regardless of their credentials or statures or the institution, who make reckless assertions accountable in the same way that we would hold anyone else. That is to disconnect it from emotion to a certain extent and really just use the tools of the norms of the field and hold them to those norms.
This whole mute and unmute life in the Zoom world is never gonna feel terrible. All right, we've got another question. Dr. Ford, you mentioned an approach in which team members in a qualitative study, your team engaged in, first assess their sentiments that they brought to the study. Can you explain how these sentiments might have influenced findings from that study?
It wasn't a qualitative study. In fact, part of the point I would have, in that one, it wasn't a qualitative study. It was actually a big data study. And my point was that we can do that kind of qualitative self-assessment in qualitative work where anthropologists, for example, already know to do those kinds of assessments, but also in our most quantitative types of work. And for us, I think because we caught what our a priori assumptions were in advance, we had our eyes more wide open going into the results. So I can't say that those assumptions impacted us because we identified those assumptions. That was our entire purpose. But the kinds of assumptions that people would have are, that they expect to see African Americans have higher levels of racism, of the racism exposures that we were looking at, and that they were poorer in terms of the outcomes that we were expecting to see.
Great. We've got time for maybe one or two more questions. Question from the audience is, accountability can be an issue for students, postdocs, and junior faculty. How can people who may be in vulnerable positions speak up without being retaliated against, fired, or treated poorly as a response?
I think it's important to have leverage from outside your unit or outside the entity in which you're housed. It's helpful to have models of others. It's also useful to use the evidence and to speak from that. There has been a lot of work. People have done so much work over the years. And so it's important to draw on what has already been done and not to feel like often one might feel isolated. And it's important to realize that there are many resources, human resources and others. And even if it feels like something, uh, you might not even realize that there are senior faculty who are going through the same thing. So um, I think it's important not to face it alone and to learn from what others are currently doing and not to, and also in the words of Audre Lorde, um, to realize that our silence will not protect us. And so those are things I would definitely recommend.
Thank you. We've got a comment just thanking you for your amazing work. And then another question, Dr. Ford, there's an apparent distrust between minorities in medicine due to, but not limited to, numerous accounts of medical abuse and exploitation, as documented, for example, in Harriet Washington's book, Medical Apartheid. How can this distrust be mended? I know that's a big question, but wondering if you have any thoughts on steps that can be taken.
I do. I think that I've been disappointed with the way that this problem has been approached with respect to the COVID-19 pandemic initially, because much of the response that I saw was there's a possibility of mistrust. Therefore, we need people to just convince those people to take the vaccine. A more responsible public health response would be, if any population expresses concern, for us to have the level of respect for that population, to respond to the questions that they express, to take the time to answer those questions. Those questions may actually be relevant for many people, not just for that population. And in so doing, enable the community members to make the best decisions that they can make on their own behalf. That takes a shift in our orientation as public health people, where we are no longer the saviors. We are maybe the bridges in terms of information. So I think that there is a lot that we can do there.
Thank you. I want to follow up with a question, just sort of in general, about public health right now. So we're coming out of slowly this crisis, this pandemic crisis. You know, from where you sit, what is public health poised to do in the next 5 to 10 years, given that, you know, on the one hand, there's been this rise in understanding of what public health is and what we do in the world, but we're also doing it in the wake of a pandemic that devastated communities that we, as public health practitioners and public health scientists, have dedicated our careers to protect, and in some cases we're unable to do so. So wondering how you see sort of this next decade of public health evolving, given this place that we find ourselves.
I think public health is in a place now where we need to shift if we're going to be relevant, and we can't be the central location, the central purveyors of information, resources, tools. This is a moment where we can democratize engagement in public health. That's where I would like to see things move.
Great. We've got one more comment from my colleague, Dr. Chandra Barber, who says, thank you. And you know, I just want to say on behalf of the Dornsife School of Public Health and myself, that was just an amazing talk, amazing discussion. I know the students and faculty and staff and community members who were tuned in today, we had upwards of 200 people listening to this talk. I look forward to a day when we can welcome you to Philadelphia in person, and not live in this virtual world. I know that we are all looking forward to that day coming sooner rather than later. With that, I will announce that the Philadelphia Department of Public Health has been tweeting out today that there are walk-up vaccine appointments available around town. So please go to the Philadelphia Department of Public Health website and see where those are. bring a friend if you can, and go get vaccinated if you have not yet. So Dr. Ford, thank you again so much. There are lots of comments of thanks popping up in the Q&A box. Again, have a great day. I know you're going to have a chance to talk with some smaller groups as the afternoon progresses, but what a great opportunity to have you here with us today. Thank you again.
Thank you so much for having me.